எங்க அம்மா எப்படி பாத்திருக்கீங்களா?
ஆமா.
I think they've mistaken some other.
Oh, I am mistaken. I'm sorry. Okay. I'm sorry.
Sophia's mother is not a doctor. Sophia is an alumni of Child's Trust.
Mistaken for our friend, like Namma Ivanga daughter, Yamuna daughter. Sorry.
Illa.
Okay.
அதுதான் thinking எங்க அம்மா எப்படி பாத்துப்பீங்க அப்படின்னு. But anyway.
அதான்.
She's a DNB student from Child's Trust.
From Child Trust. எந்த வருஷம்?
From Child Trust.
96 to 99.
அதெல்லாம் கேட்க கூடாது. அப்புறம் நாங்க ரொம்ப வயசானவங்க.
இல்ல. You look young only. Don't worry.
No, I'm just joking. So
96 to 99.
Sir, Gunasingh sir, good evening sir.
Good evening.
Good evening sir.
Good evening.
Jalil sir, good evening.
Tell me. Okay.
Jalil, good evening Jalil.
Good evening sir. Sir, Gunasingh sir, நீங்க சொன்ன மாதிரி எல்லாத்துக்கும் ஷேர் பண்ணுங்க
sir. நேத்திக்கு IAP TNSC னுடைய the Star Night program was very great. I entertained. I mean, I enjoyed thoroughly, fully. Very stressed. இது இந்த பஸ்டர் சார், அது உண்மையிலே ஸ்ட்ரெஸ் பஸ்டர் சார். சார், thank you. Hats off.
Next time குணசிங் சார்லாம் வாங்க.
குணசிங் சார் உங்களுடைய ஜோக்ஸ் எல்லாம் சொல்லணும் சார், உங்க ஜோக்ஸ்.
Okay, it is 7 o'clock. So sir, I don't know, we'll have gallery view. Okay. So, good evening, friends. On behalf of IAP TNSC and IAP Tiruvannamalai district branch, Sophia.
சொல்லுங்க சார்.
Sophia.
Yes sir, I hear you.
You are I think you want to present first.
Yeah, definitely sir. I can go first.
Okay, there's no problem. You can stop sharing. Another 5 minutes we have the inauguration.
Yeah, sure.
Okay. Just stop sharing. You are able to share your slides.
You can. So let me just share.
Right.
I will just stop.
Okay, no problem. You slide maybe it can be there, no problem. So
Sir, unmute sir. Dr. Gunasingh sir, unmute.
So IAP Tiruvannamalai district branch, it just started few months back, and it is just embryonic stage. It has to grow faster. I hope you have to give all the nutrients. We have to get it from IAP TNSC with all support. We are getting from our IAP TNSC, my parent body, and I think the IAP TNSC is doing a lot of virtual meetings, all activities. The credit goes to our President Ismail and Dr. Rajendran. And this program, actually, I wanted to just one of your, Mayo Clinic, what is that, Sambat Kumar, somebody was very popular in our place. I think many interviews and I think. And then I was thinking of Yamuna, my friend. So when I discussed with Yamuna, she contacted Dr. Snega Mogan. She is our friend, Dr. Yamuna's daughter. So she is doing second year senior resident, internship in internal medicine, residency in. intern Dr. Sneha contacted Sophia. We were supposed to be, I came to know she was an alumni of KMC and also KKCTH. So every day we see lots of programs on COVID. Okay. So I thought, what is happening in US? I just little curious about that. Is it the same or little different? It is. I just wanted to know. We have our friend, I think, a teacher Dr. Balasubramaniam, who is an expert in everything. Okay, he is all in all. Okay, so I welcome you all. And our chief guest, Dr. Jayakumar, is our dean, Kanyakumari. He is a very old, IAP member. Although he is a pediatric surgeon, he is our IAP member, long-time IAP member. He was a dean, Viluppuram Medical College, then Teni Medical College, so many medical colleges. He has seen all medical college in South India, North India, and also we were working in Arunachal for nearly 1.5 years. I was previously working in Arunachal Pradesh, a wonderful place. So we both came to Tiruvannamalai. So I welcome Dr. Jayakumar, and I welcome our president, Dr. Tamilmani, who is our senior pediatrician and leading pediatrician in Tiruvannamalai. And welcome all the office bearer, Dr. Vice President, Dr. Prabhakar, and Treasurer, Dr. Satish Kumar, all, and Dr. Karnanidhi, and Jalil is always supporting me for everything. Okay. Yeah. So, with these few words, I request our President Ismail to say a few words.
Thank you, Dr. Gunasingh. Good evening, all of you. Respected Dean, Dr. Jayakumar, our professor, Dr. SBS sir, the speakers today, Dr. Sophia and Dr. Sheila Mohan. And of course, amidst this pandemic, lot of the webinars are going on COVID. But I think, as Gunasingh sir rightly said, we are all eager to know what is happening in US. So I think Dr. Gunasingh, it's an embryo, as he said, the embryo, though it's an embryonic stage, the performer is there, star performer is there. The Sachin Tendulkar of that Tiruvannamalai team is Dr. Gunasingh. And when he plays the game, I think it is almost, there will be a century. So Tiruvannamalai is sure to rock this year in the IAP's TNSC sector. So I think with these few words, let us go for the deliberations. I hand over the mic to Gunasingh sir. Back.
Rajendran?
Yeah, yes, sir. Yeah. Respected President Dr. Ismail sir and past President Dr. Somasagar sir and Dr. Our teacher of teacher Dr. Balasubramaniam sir, SP sir, and EB member, Central EB member Dr. Jalil, and Treasurer Dr. Gopal Subramaniam and Thirumurugan, and today's speaker Dr. Sophia Pillai and Dr. Sneha Mohan, and IAP Tiruvannamalai branch President and as well as Secretary and Treasurer. On behalf of IAP TNSC, I really welcome and for that's wonderful evening. And today's topic is overview of COVID-19 and current trends in adult and children. And I think how many talk. So we are having so many topics and so many forum. We are having past 1.5 2 months. I think this is like Rajinikanth movie. So whenever you are probably releasing, I think definitely it will be hit, and definitely the program will be definitely useful. And already it's 150 delegates are there. Definitely it's useful for everybody. On behalf of IAP TNSC, I tell the best wishes and go ahead. Thank you, sir. Dr. Gunasingh sir, thank you, sir. Yeah.
Okay. Sir, Jayakumar sir. Okay, I think he is not yet connected. Oh, to Prabhakar sir is there? Okay. So, to Satish, our treasurer.
Yes, sir. Yes, sir.
Yeah, you can say a few words.
Yes, sir. On behalf of Tiruvannamalai, we welcome you to our first ever online CME with collaborating with the Tamil Nadu State Branch. I'm very happy to be associated with our branch, and this is our first activity, and hope we continue with the same enthusiasm with our young, energetic, and active our Guna Singh sir will take our Tiruvannamalai branch to newer heights, and we will all cooperate and we'll together achieve more. And on behalf of Tiruvannamalai, we welcome the international speakers Sneha Mohan and Sophia Madam for enlightening us about adult COVID and pediatric COVID. Thanks to IAP Tamil Nadu State Branch President sir and the entire team for giving us the opportunity to co-host the meeting. Thank you, sir.
Okay, thank you. Thank you very much. Dr. Somasekhar, you want to say any few words? Dr. Somasekhar?
Yes, sir. Respected the office bearers, IAP TNSC, Mohammed Ismail, my dear friend Rajendran and Treasurer Gopal, and the branch IAP TNSC of Tiruvannamalai in embryonic stage with a very strong umbilical cord blood supply, and ever not out in the team, that is Professor Dr. Guna Singh. Like diabetes means metformin not out. Dr. Guna Singh is not out in our field. So I wish the COVID-19, the overview from US, the star speakers for today, Sophia Madam and John Hogan. So, I welcome you all and I wish the function a grand success.
Thank you, Dr. Somasekhar. Now we'll go to the speakers. I think, Sophia, you are going to present now?
Yeah, I can do that, sir.
Sneha, you can talk next, okay?
So, first of all, thanks for that nice, lovely introduction, and then thanks for the invite. I have to thanks to Dr. Jayakumar, Dean, and the Sachin Tendulkar of the IAP Tiruvannamalai branch, Dr. Guna Singh, who has been instrumental in getting all of us together for this. And a great shout out to all my KKCTH colleagues and friends. I think a few of them I saw, Dr. Janani, Dr. Gopal, and many of them are there. And then also to KKCTH Medical Director, Dr. Balasubramaniam. I'm not sure we have crossed path because I left in 1999, but I'm so happy to be here. For, like as your busy day is winding down in India, we are starting our day here in the US. It's 8:30 a.m. Central time in the US. I'll keep my talk brief, and we'll have lots of time at the end for questions and discussions. And again, as I said, thanks so much for the invite. Yes.
Yeah, 1 minute. Our Dean has joined. Sir, Jayakumar sir. Sir, Jayakumar sir. Oh. Okay. I think he is not able to. Sir? Okay. I think next at the end of the lecture we will contact. No problem. Sophia, carry on. Sorry for
Sure. So that's okay. I just want to make sure that I am audible to everybody, and then you can see my screen. Can you see my screen now?
No.
Okay. So let's just give me 1 second.
Share your screen.
Yeah, I'm just going to do that. Hold on for 1 second. Share screen.
Dr. Guna Singh, you have to permit her to share the screen.
Yeah, because it says I'm sharing.
No, she is a co-host also. She can share. She was sharing in previously.
Yeah. Can you see me now?
Yeah.
Is my slide screen seen?
Yes.
Okay, right. Okay.
Yes,
right, okay,
yes,
right, okay,
yes,
right.
yes.
Yeah.
Okay, right. So I'm just going to make sure. Okay. So just a little brief about me. As I said, like my pediatric journey started at KKCTH. This was, like I finished in 1999. Prior to that, I had my medical education from Keel Park Medical College. And after I got my Dip and B pediatrics, I left to United Kingdom, where I was a specialist registrar there for quite some time. And then I moved to the United States, where I completed my residency and pediatric pulmonology fellowship. And now I'm currently assistant professor and consultant in pediatrics and pediatric pulmonology at Mayo Clinic. And again, I'm very honored to be here today with you all to share an overview of pediatric COVID. The slide doesn't seem to move. Okay, right. So today, you can still see the screen, right?
Going.
Okay, okay. So the objectives. Okay, so the objectives of the talk today basically is to have an overview of the current trends, the clinical features, management and outcomes pertaining to pediatric COVID. We will also touch upon special situations, MIS-C, high-risk groups, pregnancy and breastfeeding, and then really talk about in general, how can we end this pandemic? And then lastly, we'll finish with general measures that we need to follow and a few words about vaccination. I do not have any financial disclosures to mention. There's no conflict of interest. The contents of this presentation do not reflect Mayo Clinic policies or recommendations in any way. And most of the information which are presented today are current as of today. So to really understand the pandemic, we need to know about the history of coronaviruses. So we have 4 human coronaviruses in circulation. So they are seasonal in nature, meaning that during fall or winter, they have children can actually present with a brief history of nasal congestion, cold, cough, fever. Most of them are asymptomatic and they recover from these cold infections. They can have multiple colds within that one particular season. Most of the kids, as I mentioned, are asymptomatic, but they can become symptomatic when they have a co-infection, the usual offenders being rhinoenterovirus, respiratory syncytial viruses, influenza viruses, and other common viruses. So coronaviruses are basically common cold viruses. These coronaviruses are extremely notorious because they are RNA viruses. They mutate like crazy and then they recombine. So why we call it's a novel virus, because when it mutates and when the transmission happens from zoonotic animals and birds to human, that's when we have this novel infections, because we are not used to or exposed to these infections and the system is not prepared. So 2 of that had happened earlier. So the first was, like the SARS-CoV, which appeared in China in 2002, the reservoirs being bat. Again, in this, most of the children were asymptomatic and then did not have a major impact in children. And the second one was the MERS-CoV, which again appeared in, like in 2012, the likeliest reservoir being camel. Again, children were mostly protected from this. And the current COVID-19 is severe acute respiratory syndrome, CoV-2. So this, like now we are seeing, like the pandemic, which is causing ravage globally. But when you look at children, like the majority of children seem to be relatively well protected during this pandemic. And we will go into the details of that sooner. So the pediatric COVID, as I mentioned, forms a very small proportion when compared to adults. Nevertheless, like it is important, but when compared to adults, it's, like low. The American Academy of Pediatrics thinks that, like this, actually the rates of infection which are reported is an underestimate, because most of the children are asymptomatic or have mild illness and may not get tested. That could be one reason. And nearly globally, 3.6 million children have been infected so far. In the US, as of mid-June, the infection rate is around 10 to 14%, 10 to 14% in children among all of COVID cases. So children of all ages can be affected with SARS-CoV-2, from neonates to adolescents, and we have literature to back this fact. So when we separate children. So when we say children usually we say from 0 to 20 years. And even, like when we divide this group into less than 5 years and over 5 years, we see that the younger the child is, the more protected or less severe or more asymptomatic these kids are. There could be, like a few reasons for this. One, young children are mostly homebound. That means, like they are less likely to have an infection other than from a household contact. And the second, as I mentioned, probably they also have some innate or adaptive immunity because they are exposed to this circulating human coronaviruses. That's, like one reason why we think in the 0 to 5 year or less than 5 year age group, the infection rate seems to be less than 2%. And the majority of the pediatric infection is formed by, like children above 5 years of age. And the hospitalizations, when compared to adults, seems to be low, and it remains low. And mortality also seems to be way less when compared to adults, around, like 1%, less than 1%. So having said that, we all know that asymptomatic transmission still forms a major reason for, like the continuing spread of virus in the community, and also, like in all this the big gatherings. So the one thing which is unknown is how efficiently the children can transmit the virus, or do they really transmit the virus, and how efficiently, because we think most of the children are asymptomatic. Their viral load is much less compared to adults. And then the burden of infection in children is actually difficult to quantify globally, because, like testing standards are not uniform, and not all countries have resources for testing children who are asymptomatic or, like with mild illness. So this is just, like a picture which shows, like the different states within the United States, which reports the hospitalization rates in the US. And this is from the American Academy of Pediatrics. And if you look at the far right of the hospitalization rate, you could see it roughly stays around 1% or less than 1%. That's the hospitalization rates in children in the United States from 0 to 19 years of age. So far, I mean, we are 1 year into this pandemic. We know that children relatively seemed, like safe. But then we recently saw a worrying trend when we actually had 204 adolescents who were admitted. So after a peak in the hospitalization rate in January of this year, up to 2.1%, we saw a major decline to 0.6% in March. But again, in like late March, April, there was a surge back to 1.3 among adolescents, like hospitalization rates. And then what was worrying also was 1/3 of this admission actually needed intensive care monitoring. And 70% of these children, adolescents, actually had one underlying comorbid or medical condition. So what we think was probably this medical condition must have predisposed them to have the COVID infection in the first place, or to cause severe COVID illness. But what was more worrying was, like 30% of healthy adolescents also were seeing severe COVID-19 infection. So we'll come to this later, why, like this is happening. But this is, like this actually got all of the pediatricians worried in the US and also globally. So to understand the pandemic, like we also need to know how the SARS-CoV-2 enters, or why SARS-CoV or the COVID-19 has a plethora of symptoms. So because, like for the SARS-CoV to enter the host cell, it needs to have fusion with the ACE2 receptor, so the angiotensin converting enzyme to receptor, which is present everywhere in our system. That's why we are seeing, like mostly, in the lung, type 2 pneumocytes, which actually produces surfactant, but it also present in the heart, the kidneys, the blood vessels, brain, everywhere, you name it. So you can actually see the plethora of, like symptoms we are actually seeing in COVID, mild COVID, and then severe COVID. So the summary of three meta-analysis actually showed that fever and cough were the most common symptoms reported in children. So in like in the majority, so probably like 50% and over. What they also found was, like there was a handful of, like 2,000 children from the Chinese children early on in the study, where they also found that like adults, the distribution of symptoms was similar in kids too, like with rhinorrhea, myalgia, fatigue. Anosmia was not, like mentioned earlier, but the recent studies are actually saying, like anosmia is also mentioned in kids. But as I said, fever and cough seems to be the most common presenting symptoms. Again, most children remain asymptomatic or with mild symptoms. What we have seen is children have fever, brief fever for a day too, and they can probably have, instead of fatigue, they probably will have refusal to eat. Those are the things we see commonly in children. Again, when we look at the labs, most of the children don't end up having labs, but the children who get hospitalized or who are in the path to the, like severe or COVID infections tend to have labs, which, like usually the lymphocytes numbers can vary, but lymphopenia was mostly noted, which doesn't seem to have any prognostic value. But what we also found was inflammatory markers, which if elevated, seem to actually go in or tie in with severe COVID, as we all know that, like higher, inflammatory states are associated with progressive lung inflammation or systemic inflammation, and of which, like as I mentioned, CRP, and then white cell count can also be higher. These actually have prognostic value, or also can say that can tie with the severity of COVID illness. Let's see. So next, like when we look at lab imaging, as I said, like most of the children don't need any lab or, like labs or even chest imaging. Like in adults, we have seen that children who have severe COVID or who end up in the intensive care tend to have ARDS-like picture with bilateral consolidative opacities. And as I said, like the ACE2 receptors are usually present in the pneumocytes, which are used for producing surfactant. And when your surfactant depleted, you can have all these changes. Even in children who are not very symptomatic or even mild infections without oxygen desaturations, we actually have seen chest X-ray abnormalities. So the chest X-ray abnormalities can be there in children who are, like who will not, it does not say that, like they are going to definitely progress to severe infection. It just says that they have lung inflammation. And most of them will recover at this stage and will not progress further. So the next, coming to the special groups. So what they found was, like when they did a study of the JAMA network, actually had said like when they included 43,000 children with COVID-19 diagnosis from March 2020 to January 2021, the risk factors for hospitalization, which stood out was, like type 1 diabetes with a risk ratio of 4.6%. That means if I have type 1 diabetes, I am at 4.6% higher risk for contracting COVID or severe COVID. And the second was followed by obesity. And then the risk factors for severe COVID illness, again, like in type 1 diabetes, or if I have cardiac and or circulatory illnesses. In the less than 2-year-old, what we found was, I just have to adjust my screen. What we found was, BPD prematurity, and then prematurity seems to be, and BPD seems to place the children at higher risk for hospitalizations and or severe COVID. So this again is like a pictorial graph, just saying that type 1 diabetes and obesity, if you have these two risk factors or underlying medical conditions, you're at higher risk for one, getting COVID or having severe COVID infections. So then among the hospitalized children with COVID, as I mentioned earlier, that we found that 70% had an underlying medical condition. And the most common were, like asthma, being the most common underlying medical condition in 10%. So what I'm trying to say here is, like when children come to hospital for a COVID or a COVID related, hospitalization for a COVID related illness or, like unassociated, what they found was most of these kids have, or at least 10% of these kids have asthma. But having asthma per se does not predispose you to having severe COVID illness. They had an underlying diagnosis, but this did not, put them at risk for severe COVID. So then moving on to the next special group is, like MIS-C. So MIS-C is multi-system inflammatory syndrome in children. So here, now instead of the lung, the inflammation just being confined to the lung, now I have systemic inflammation. So the major organs being, other than the lung being your heart, your GI system, and or, the brain. So the case definition by CDC and WHO is, if you have presence of fever for relentless high-grade fever for more than 24 hours, along with elevated inflammatory markers and multi-organ dysfunction, more than 2 systems being involved, the suspicion of MIS-C should, or, we need to make sure that this is, this is MIS-C unless proven otherwise. And, in India, we need to make sure that there are not other diagnoses, the common ones being, dengue and malaria, and then I was told scrub typhus too. The interesting thing with MIS-C is, it does not have, the temporal association with the acute COVID-19 infection is anywhere from 2 to 8 weeks. So if I'm at the far end of that time spectrum, so 8 weeks, many parents might even forget that their child had COVID unless, the symptoms were severe. So the RT-PCR test usually will be negative, but then most of them will have, the antibody positive titers for COVID. So this is how we know that there was, they have been exposed to this infection earlier. Again, the common clinical features being cardiorespiratory involvement, and this MIS-C seems to affect this 8 to 12-year age group and not the younger ones. So how do we know that this is not, Kawasaki's? Because when it first came on, the question was, is it Kawasaki? And we all know that Kawasaki has, a higher predisposition in, Asian kids, and also following, any recent infections. So with Kawasaki, they'll have, most of the symptoms similar, but they also have predominant mucocutaneous symptoms, whereas COVID seems to have more cardiorespiratory symptom presentation. So again, this is a recent publication from February where they found the characteristics and outcomes of US children and adolescents with MIS-C and severe COVID. So they looked at 1,000 patients and they showed that 6 to 12, so the age group 6 to 12 years puts you at a higher risk, or 1.5 times higher risk to have COVID versus the less than 5 years age group. And as I mentioned earlier, predominant cardiorespiratory symptoms. And then MIS-C has a higher risk of cardiac involvement versus a respiratory, and they have a higher inflammatory markers and slightly higher mortality rate compared to severe COVID. But what we also found with relation to Kawasaki's is, most of these kids who have coronary artery aneurysms it tends to resolve by the time they get discharged, suggesting that it's not an inflammation, but rather, a vasodilatation because of the severe illness. So most of them have shown that, the coronary artery aneurysms have resolved by the time they get discharged from the hospital. So in infants in less than 2 years, again, less than 12 months, again, the MIS-C can happen, but the manifestation seems to be less severe when compared to the 8 to 12-year-old age group. So the next, coming to my, my specialty. So when we heard about the pandemic, most of the, the pediatric pulmonologist, and parents were extremely, and pediatricians were extremely worried because, like, I already have an underlying lung issue, and how am I going to, or my child going to react to this virus? So the European Respiratory Societies actually sent out a questionnaire to many different centers. So 94 centers responded with bringing the total of 945 children. So these are basically asthma clinics, any respiratory clinics taking care of children with asthma, cystic fibrosis, non-CF bronchiectasis, and other chronic respiratory conditions. So what they found was majority of the kids, especially like in asthma, as I said, majority of them did not need treatment. And then the CF population, again, like majority did. So there were 14 children identified, and then 10 actually did not need treatment. But what they found was children with chronic developmental disorders like BPD and other respiratory illness, like with neuromuscular illness, they all needed hospitalization or some form of respiratory support, either invasive or non-invasive. This just shows that, like the severe my underlying lung condition, the more severe the COVID infection or the way I handle it's going to be. And the other thing also is, like cystic fibrosis patients know that they need to be very careful. So they were probably maintaining or following all the COVID appropriate behaviors, and the similar thing with asthma too. So they found that, like social measures tend to help these kids to stay safe. So now just talking about the COVID treatments available, I'm not going to go into the details. Already Indian Academy of Pediatrics has a very robust guidelines, which Dr. Gunasingh shared with me. But what we need to understand is, like there are different phases. The first is the viral response phase, where the virus is in my system, but I haven't started showing signs yet. This is the asymptomatic or the pre-symptomatic phase. So we have to be judicious here that, like this is the time that we should, like the virus is actively replicating. So there is no role for any medications other than, like a symptomatic treatment. And the second is when, like the host inflammatory response sets in. And then we have some medications which have been shown to be beneficial in this particular phase. So acute COVID-19 management in children is like any other illness where standard pediatric lower respiratory tract infections and ARDS management applies, and majority is all supportive care. We also found one study, or in like a couple of studies have actually mentioned there is a high risk, like 20% chance for a co-infection. So if you're thinking the clinical symptoms doesn't match or seems to be out of proportion to what the child with the COVID-19 should have, early bacterial antibacterial treatment should be instituted, especially in kids who are like in the intensive care or are needing escalating respiratory treatments. We usually don't go down the route of IVIG or IVIG unless it's MIS-C. And then we also consider prophylactic anticoagulation, because we know severe COVID and MIS-C kids have a very high proportion for thromboembolic disorders. And then in centers, like where they have ECMO, so if we think that the kid is not actually doing well or needing escalating treatment, they need to be transferred to a place where they have ECMO facilities. And as I mentioned earlier, like most of them, like will become better. They have, like will not progress into the severe COVID phase. And if at all, they will need supplemental oxygen to maintain the saturations above 92% or 92 to 95%. And if they need escalation of treatment, we usually say non-invasive, though we know, like aerosol risk is higher. If they are maintained in respiratory isolation, non-invasive ventilation is still the first step. And if they need intubation, it should be by a skilled practitioner. And again, as I said, because if like aerosol dissemination of this virus, it should be by a skilled intensivist or an anesthetist. We don't have much literature on the effects of prone positioning or in children, but we still do this, like for ARDS, we still do this. So, like we can trial this if we think this would help the child. But as I mentioned earlier, it should be supportive care, early antibiotics, and then prophylactic anticoagulation, and to be in a center where ECMO is available. I'm not going to talk much about the rest of the treatments because if you look at the recent WHO guidance, they don't have any literature, even in adults, on many of the treatments which have been kind of trialed or used. But the one thing which has stood out was steroids. So steroids has shown a benefit when, as I said, when the inflammatory state has set in. So that means we really need to be judicious in the timing of steroids, when to use it, how to use it, and how long to use it. So we typically use that for 7 to 10 days for children who need, intensive care, or who need escalating oxygen requirements, or whose saturations, kind of worsen. These are the kids we typically tend to use steroids, and usually for a period of 7 to 10 days. When I'm using it for 7 to 10 days, I don't have to worry about adrenal suppression or other common side effects which are seen with steroids. And what they found was, there was a mortality benefit both in a critical illness and severe illness when corticosteroids are used at the right time. I think we talked about this. And again, this is the IDSA randomized trials again, which actually showed one, that the severity of illness can be made better, or the mortality benefit when we use steroids at the right time. I think I talked about this. So, just to mention about remdesivir, WHO basically has said, it should be a special situations. The remdesivir usually acts by premature termination of the viral RNA transcription. Here, in my practice, it has to get the approval from the ID specialist before they give remdesivir. It's not part of regular protocols or treatments. I'm going to skip monoclonal antibodies, and I'm going to skip all this. So as I said, remdesivir, the WHO has come out saying that, it doesn't have any, it doesn't make big differences. So it's a case by case basis. So now moving on to the next high risk groups, maternal and neonatal morbidity in pregnant women with and without COVID-19 infection. So this study was done between March and October of 2020. In 18 countries, 43 institutions took part in the study. And then the inclusion criteria, any stage of pregnancy with and without COVID infection. So what they found was, they had 700 pregnant women with COVID infection and nearly 1,500 pregnant women without COVID infection. What they found was overweight was seen in early pregnancy in pregnant women with COVID infection. But what was more alarming was women with COVID infections were at a higher risk, at a risk of 22 times higher risk for maternal mortality just because of COVID. They also have higher incidence of preeclampsia, severe perinatal mortality needing NICU stay, neonatal deaths before discharge, preterm births, and severe neonatal morbidity leading to hypoxic ischemic encephalopathy, bronchopulmonary dysplasia, sepsis, and IVH. So basically, it just shows that, in pregnancy per se, is a disadvantage, especially when it comes to lung function because of this gravid uterus. Your lung capacity is reduced. On top of that, if I were to have COVID infections, I'm going to be at a higher risk for severe COVID and maternal and neonatal morbidity and mortality. What they also found was COVID positive pregnant women, even if asymptomatic, still were at a higher risk for maternal morbidity. And then there was also a risk that the neonates were tested positive. C-section actually was associated with a higher chance of the neonate testing positive for COVID, but breastfeeding actually was not associated with the neonates being positive for COVID infection when the mother had COVID. So next, moving on to the breastfeeding. So what we have been recommending our mothers was that, if the mother is clinically stable, then she should be allowed to continue to breastfeed, but mother should wash her hands, should wear a mask. We also say that, if they can actually change their clothes prior to every feeding session, that would be ideal. If they have some other caregiver at home who can take care of the child between feeding sessions, that is very welcome. But many mothers might not have that luxury. If that's the case, what we suggest is, like, to have the baby in the same room, but a well ventilated room, so that like there is not so much of aerosol, spread of infection to the baby. So then now talking about, like, how can we actually, contain or, like, curb this pandemic? So they did a study and they found that, this was actually a model. It's actually not a study. What they found was almost 60% of transmission actually came from asymptomatic transmissions, which could be either, like in the pre-symptomatic phase or truly asymptomatic phase. So what this all reinforces is that even though, like, we have, many of us had natural immunity, either because of vaccination or through natural infections, we continue to follow this COVID appropriate behaviors, because there are so many vulnerable who are probably left exposed if we don't follow these guidelines or measures. So that, like, brings us to the topic of universal masking, hand washing, and distancing. So initially, like, when the start of the pandemic, the idea was it was all from droplet infections. So droplet means, like, it's the larger size infection, larger size larger size deposition. That means, like, it's not going to travel in air far. That means, it's just going to stay, drop to the surfaces nearby. And then, like, fomite transmission was thought to be one of the main reasons. But as we learned more about it, we now know that, like, this airborne transmission is happening. Airborne means, like, it has become an aerosol that's very small in size, that it suspended in air. It can travel, like, longer. So that's why, like, we say by universal masking, the idea behind that is, like, we are trying to curb the viral load. So when I say viral load, just to put, like, given a simple example, if I have a 50 virus entering my system has a capacity to take care of it, like, by mounting an adequate immune response. But if at the same time I'm exposed to 5 lakh or 5 million viruses, my system is going to be overwhelmed. So just by having a mask, like, if your nose actually is an effective filter. So the two functions of the nose being, one is, like, it's filtration. The second is humidification. By filtration, I keep all the bacteria, viruses, and the substance which doesn't, or the viruses or bacteria which doesn't belong to my system, out of my system, by having, like, an effective nasal filter. The second is, like, having the external, the second additional layer of mask. We can also reduce the amount of viral load or inoculum, because that's what also drives or triggers the severity of COVID. And then the second is, like, the 6 feet we talked about is just for, like, the droplet infections. But we know that, like, aerosol transmission can happen. That's why we say to have well ventilated rooms or offices where the airborne transmission is actually, like, mitigated or reduced. I think we talked about this. I think I said this too. So, like, there are actually many studies, like, both in community level, state level, even like, even a hair salon in one of the states, they actually have found that just by, this is all before, like, the vaccination came into effect, by following simple general measures, we will be able to curtail or curb this infection from spreading or having local flare-ups. So now moving on to the current vaccines, like, how is, there's a lot of myths about the COVID-19 vaccines. The two vaccines which we have in the United States are mRNA vaccines. So traditionally, vaccines are developed, like, based on inactivated, like, the bacterial or viral particles. But with mRNA vaccines, what we have been trying to do is we are actually trying to have that particular protein. So in this case, like, we found that the binding and the neutralizing antibodies to spike protein. So that's the one, like, which actually gives or offers protection. So we are trying to trick our system, or not trick, like, tell the system that, like, now I'm exposed to this small amounts of spike protein, and then I develop immune response to this spike protein. So what we have found, at least in like most of the studies in like the 2 mRNA vaccines we have, is one is in like Pfizer and the other one is Moderna. So mostly they are 90% effective. So when I say 90% effective, when I give it to 100 people, 90% of them will have an immune response. So what we also found is, again, like this is all based on prediction models, is if we have a 90% effective vaccine, and if at least 50% of the population is covered, we can then have herd immunity. So what I actually mean by herd immunity is that means the threshold immunity where the infection rates does not continue to rise. That we are still in the pandemic phase because we are still seeing rise in infections, and also like in pockets where it's just having a surge. So we're still in the pandemic phase. For us to move into the endemic, or so most of the pandemics will eventually become epidemics. When I say epidemics, it's like like influenza viruses. It's an epidemic every season. Like we have a surge, and then it like the rest of the time it is the same as the previous years. So this pandemic also will become epidemic, but for that to happen we need to have herd immunity, so which can be achieved by two. One is like natural infection, which like is not acceptable with so much of adverse outcomes and mortality. The second is vaccination. And many countries for many reasons like we cannot achieve this vaccination in countries like India. There is a shortage of vaccines, but in countries like US, like we don't want to take vaccines because we are worried, because it's a new vaccine, nobody wants to take vaccines. So we are going to continue to see many of these infections or infection surges which happens. And the other question is about the different variants. What are these variants? So the variants just tells that there is like the virus is still in circulation. As I mentioned earlier, RNA viruses tend to mutate like crazy, and then the moment like they find a suitable host, they're going to mutate so that it becomes either extremely transmissible, as we saw with the Delta variant, which is currently in India, or it can just be like not so bad. So the question which is lurking for the pediatricians then is like, now we are seeing an increasing spike in children. Is it because the virus is truly very highly transmissible, or is it something else? So from at least from the US data, what we could see is majority of like the older population, 65 years and above, have been like at least it had one vaccine, and many of them had actually had the second vaccine too. And we have rolled this down to up to 12 years now. So more and more the younger population are also affected. So the others which are now left out of the 0 to 12 years. So we will see infections, but not severe infections as we saw in the adult age group. And as I said, like FDA has just approved the vaccines for children up to 12 years of age. And then just to end my talk, I have to thank, like when this all first started, when we are hearing all the stories in India, like it was heartbreaking, because to see my people suffer, there was no oxygen, there was no beds. So we actually partnered with Yuvati, which is an NGO organization in Chennai, who actually was doing great work on mental health awareness in children and women before all this pandemic. So we partnered with them, and then the brainchild, like the brain behind all this was, like Dr. Amulya Rao, who is one of my best friend, who got us all together to, like help with creating a Facebook handle where we vetted all information about COVID, so we can have authentic, legit information on COVID, both in English and adults. And you can see all this in like posters we created. It's not just about COVID, like COVID and like pediatrics, and how like sleep issues, like general measures. And we also, what we did was like also like one of my other colleague, Sadhana, like my classmate from KMC, she did televisits, like she was talking to families, helping them like stay at home, monitored them, so that like we can give medications, because bed availability was like a huge problem. So if we can actually keep people at home and then give them medical advice or share our expertise, we can actually help people who truly need hospitalizations. And then a generous donation from, again, one of my classmates, where we printed nearly 50,000 posters. If you see in Chennai, every nook and corner has this poster this gentleman was viewing, like you don't need to read or write. It's all pictorial description of, like how you can keep yourself safe during this pandemic. And also a great shout out to Sharanya Bakiraj, who's, like a social reformist, social activist, who helped us with, like putting out these posters, getting people, like oxygen supplies. I mean, Yuvati actually did that. So they did medicine kits. They actually provided meals for families who were completely quarantined. They found beds. We actually kept few patients at home on oxygen concentrators, and most of them actually, like got better, or when they needed, we also found beds for them in the hospital. And with that, I would like to end my talk. If there are any questions, I'm happy to take at the end. And again, thanks for this lovely opportunity to meet you all through this forum. Thank you. Back to you, Dr. Gunasingh. I'm just going to stop sharing.
Thank you, Dr. Sir, thank you, Sophia, for the lucid presentation. And now I request our Dean, Dr. Jayakumar. Jayakumar is there? Sir? Yeah. Please, sorry for some technical issue. Although it is little late to inaugurate, we will be happy to invite you. It is our Dean, Dr. Jayakumar Paramasivam. I think he is having a lot of experience in administration. Also, is a long-time IAP member. We were working together in Children's Hospital Egmore for nearly 35 to 40 years. He was our leader, leading us in Tamil Nadu Government Doctor Association. He was IAP Chennai District Branch. And also, we have occupied various, as dean in various hospitals in Tamil Nadu, Pondicherry, South India, North India, Arunachal, and also now, finally, we are here in Arunai Medical College. We are yet to get, we are preparing to get the LOP. I invite Dr. Jayakumar on behalf of IAP TNSC and the Tiruvannamalai branch. I happy to invite you, Dr. Jayakumar, to inaugurate this important CM.
Anyway, thank you, ladies and gentlemen. Ms. Pillai, Sugandhanamon.
Is that?
Ms. Pillai is able to hear me?
Are you talking to me, sir? Yes, sir. Yes, I can hear you, sir.
No, I just asked Sugandhanamon.
No, I think she is
Tamil, not Tamil, sir. Tamil Pillai.
Sophia and Marancha. Anyway, it's difficult for me to have a detailed inauguration because the session is already started. I do not know how long it's going to use the minds of the pediatricians available.
Little louder, sir, if you don't mind. Little louder.
I don't know how long it's going to take for 234 people, 245 people to raise questions and ask this and that. So it's only going to be a formal invitation. But anyway, being a pediatric surgeon or associated with pediatrics for a long number of years. So I do come across a lot of this, and I'm literally worried about my granddaughter who is 16, whether to vaccinate or not to vaccinate and so on and so forth. But secretly, I'm going to give her a vaccine, like I had the third dose, without anybody's knowledge. So I formally inaugurate our meeting, Zoom meeting. So let everybody deliberate to the effect that some knowledge can be shared among ourselves. Let it work for the community. Okay. Thank you, gentlemen and ladies. Pillai, நீ தமிழ் பேசுவேன் எனக்கு தெரியாது.
நான் நல்லா தமிழ் பேசுவேன் சார். தமிழ் பொண்ணு நான்.
இன்னொரு நாளைக்கு பேசுவோம். சரியா?
Definitely, sir.
நேஹா மோகன் யாரு?
Neha Mohan, she is our pediatrician, Dr. Yamuna's daughter.
Achha.
We were working in adolescent IAP chapter for a very long time. She was the IAP Chennai City branch secretary when I was the president. So her mother is a close friend of mine.
When are you going to treat me? I'm still in the adolescent group.
Pardon, sir?
When are you going to treat me? I'm still in the adolescent group.
Okay, maybe next birth.
So anyway, ladies and gentlemen, take care. Much more important, my suggestion is we need to be alive to see others are alive. So you must take as much as care as possible to stay in the world as a living being so that we can save a lot of people in the world. I really do not know what's going to come for the third wave. Let's wait and watch the fun. Nothing is not possible by us. The medical journalists can take a lot of insights, but still we work for the curing of the disease and rest of the children. So have fun. Take care.
Thank you, sir. So, Sophia, you are there?
Yes, sir, I'm here. I'm just answering some of the chat questions. I'm very much here, sir.
You know, we'll just quickly take some questions. Good on Sophia. You mentioned about early use of antibiotics in acute COVID and prophylactic anticoagulant in kids. What is your take on this, Dr. Jalil?
So yeah, so I actually was trying to reply to him. So what we have found was if the for some reason my video is not coming. So if the clinical presentation is out of proportion just to that COVID diagnosis, or if the child is worsening very quickly. So as I mentioned earlier, there is like a 20% chance that they could have a bacterial co-infection. So those are the cases where we institute antimicrobial treatment earlier, because as we all know, like as pediatricians, we all know that like most of these kids will have a viral respiratory process where they don't need additional antibiotics. But when we see that this doesn't seem to fit in that viral picture, then we can as I said, we can do earlier antibiotics. The second is studies have shown that severe COVID-19 and misc has a very high proportion for thromboembolic phenomenon. So these are the two situations where we actually do prophylactic. When they have severe COVID or misc, then they have prophylactic anticoagulation.
Okay. Next, Dr. Tangaveli, you are there. You have a lot of questions, I think. Can you talk? Can you ask the speaker directly?
Yeah.
Yeah.
Thank you, Sophia. It was a very nice talk.
Thank you, sir.
Just want to ask, type 1 diabetes, recently, we have a good cohort of type 1 diabetic in our hospital. We had increased incidence of type 1 diabetes, new onset type 1 diabetes presenting as DKA. But fortunately, none of them developed a serious illness like known diabetic children. They did not develop any serious illness requiring ICU care. That is one point. And you said that is a high risk for severity as well as for ICU admission. Is it related to the duration of diabetes? Like a child with 1 year diabetic age child may not be developing a serious illness. A child with a 10 or 15 years of diabetic may end up in PICU. That's what I just want to clarify.
Right. So you bring up 2 points, sir, because we already know that, type 1 diabetes, we have seen that we have known that it's probably precipitated or unmasked after recent infection. That's what we are seeing with COVID-19 too. And second, to the severity, as you mentioned, one is duration, and the control of how well controlled my diabetes is actually plays a major part in how well or how I'm not going to handle this COVID-19. I don't have much details about this, but this is what I know, the duration, and also how controlled my diabetes is will dictate how I'm going to handle COVID-19.
Thank you, Sophia.
Sure.
So, Dr. Somasekhar wanted to ask, is fever more than 24 hours you need to suspect miss? Just short duration fever.
So before they used to say 5 days and above. So for the Kawasaki's, we used to say it's 5 days and above. Initially they were saying 2 to 3 days. Now 24 hours and over. And if it is relentless, high grade, relentless fever, because as I said, most of the kids, in the cohort, we found that, they have mild fever, and then most of them, they don't have any other. So you have high grade fever. Additionally, you should have 2 or more system involvement, your suspicion for MIS-C becomes higher. I'm not saying you should diagnose, but your suspicion for MIS-C becomes higher because there is no point delaying care or monitoring. These kids need to be in a hospital to be monitored.
Okay. Sir, Jaykumar sir, you have any question? Comment?
Sophia?
Yes, sir.
You're with us?
Yeah.
Sophia, it's like this. I'm a surgeon, so I don't understand much of your languages. It's all Greek and Latin to me. But what I would like to know is, how is that the comorbid conditions, like particularly diabetes, is influencing the infection to grow multiple times faster than the rest of it? What is the link? What exactly is the link is happening? We keep saying comorbid.
So
incidental finding, or does it got to do anything?
I mean, I am not, I think, probably Dr. Sneha Mohan may have more because, we don't have so much of, diabetes and related stuff. But I have to think about this and then get back to you. Just to answer your question, diabetes in itself, we know that it's a forerunner of many issues. It's not just, diabetes, sugar control. It has, what shall I say, ripple effect on multiple organ systems. So I think that is one of the reasons why we are seeing, they are set up for anything which is severe when it's a small, like a mild infection in many, whereas a diabetic seems to have a, like a severe, the severity is higher. Maybe, like Dr. Sneha Mohan can add to my comment.
Yeah, I understood, but we say when we detect diabetes in children, not in children, adults but in particular, we say it's a way of living. You may have diabetes may be infecting all the other organs, but we say it's only way of living. It's not a disease by itself. In that case, my only question is, what is the connection? I'll wait for Sneha Mohan's answer. Thank you.
Sure. Thanks.
Take care.
So our dean actually is around above 60. I told not to go to COVID ward. We got a maximum of 200 cases at one point of time. But he boldly went around, took rounds inside the ward. I never dared to go inside the ward. So he may be having more experience than many of us.
I have finished my endings, but Singh doesn't want to end his endings so soon.
Okay, sir. Then I think, what about Miss Neonatal Infection in USA and their outcome? Quick fire answer from Sophia.
So the MIS-C, as I said, there is slightly higher mortality risk when compared to severe COVID. But again, as I said, the proportion of kids, the adolescents with MIS-C is actually small. It's not very high. So far it's good. And many of the kids, get better. Definitely there is, the mortality is there, but nothing compared to adults. And especially in younger children, as I mentioned earlier, less than 12 months, they do get MIS-C, but their outcomes seem to be much better too.
Okay. So thank you. We have some more question at the end of this session after our SBS comments, everything we will have, I think, because some of the question may be answered during Sneha or our expert SBS comments. So now over to Dr. Sneha. She's, we all know, she's doing second year residency in internal medicine in Mayo Clinic, Minnesota State in USA. And she did the MBBS in AIMS. I think we passed through with flying colors. And more importantly, she is our friend, our Dr. Yamuna's daughter. Over to Dr. Sneha Mohan.
Thank you, sir, for that introduction. And so nice to be in this venue with so many people watching as well, and such an honor that you thought about me when you were organizing this program. I've grown up with seeing IAP conferences along with my mom, and it's nice to see so many familiar faces here who have seen me grow up and have known me from even before I thought about doing medicine. So it's really exciting, and it's such an honor to be here. And also this is my first presentation in a public forum like this. So it gives me a lot of pleasure that I can share this with you here. So I hope that my slides are visible.
Can you?
Visible,
so-
visible.
Okay. All right. Okay. So I'm going to be talking about how COVID-19 has evolved over the last few years and how it is right now in 2021. About a year and a half ago, when the pandemic first began, I remember one of the fellows I worked with said everything is going to blow off in a couple of months and things will get back to normal. But here we are in 2021 in the middle of it, and things are still going on. Now it feels like COVID is going to be part of our daily existence, and how we approach this and manage this is something that we're all getting educated on, and right now on a Monday evening back in India. So I'll continue to proceed. So just a brief disclaimer that the contents of this presentation don't represent Mayo Clinic Institute's policies or any recommendations. No conflict of interest, and all the information here is current as of June 27th. And the way things are changing, so many things change within just 24 hours with respect to COVID. So the objectives of my talk specifically is to look at the epidemiology right now of COVID virus, and as well as focusing on prevention and how to really tackle the ongoing pandemic. And there's so much that we can talk about. So what I wanted to focus on really was outpatient evaluation and management of COVID-19 in adults. The reason being that I feel that all of us get approached by family members, relatives, and especially relatives of pediatric patients with so many questions about testing, how they should approach situations if they test positive, and how to look at mild infections, which can be managed as an outpatient. And there are a lot of fears about complications, and also fears and concerns about different therapies, and questions about evolving therapies as well. So that's what I'll be focusing on in today's talk. So first, the epidemiology of COVID-19. So the spread of COVID-19 has been pretty alarming over the last few months. And though all of us have been restricted on travel, the virus has certainly traveled all over the world. And here's a picture showing how it's boomed across every continent in the world. The first case, as everyone is aware, was detected in Wuhan, China. And the first case in the US was in Washington State, just a month later, January 2020. And this was detected in a traveler, in an individual who traveled to Wuhan. And the first case in India was detected in Kerala, once again, in a student who was returning from Wuhan. So definitely, at that time, it was all traceable spread from one location to the other. And after 1.5 years, right now, this is the graph showing daily cases across the world. So a total of 180 million cases, or 18 crore cases that have been detected so far, with a large number of deaths as well, which has devastated people socially, politically, economically across the world. So a huge burden of disease, and it's definitely a public health crisis. Cases in the US, this is a graph that represents that, where we can see distinct waves of disease, where the first one was between June to August of last year, a pretty small wave, and then the larger wave that we noticed between October till February. Right now, fortunately, cases have tapered off, and it's been pretty stable over the last few months. Some of it attributed to vaccinations, a lot of it also just to social distancing measures and lockdowns that have been instituted across different states. And here's a similar graph looking at how cases have progressed in India. And similar to how there was a first wave and a second wave globally and in the US, there was a first wave between August through December. Things looked like it was getting much better, and then we had the unfortunate second wave, which everyone is painfully familiar with, just because of how it has been devastating different cities, hospital systems, and led to many infections and many more deaths than what was anticipated. It's fortunate to see that the cases have been dropping off. The hope is that this stays the same. Part of the reason for the ongoing pandemic is thought to be from COVID-19 variants. And these variants are named according to the Greek alphabet, alpha, beta, gamma, and delta. And they're named after the locations where they've been identified in different locations across the world. To avoid naming them based off of the location, so this is the system that's been developed. So alpha is the one that was detected in the UK, beta is from South Africa, and gamma is from Brazil, and the delta variant, as we know, was detected in India. There are different terminologies for how these are referred to, and I'm just going to go over these because these come up in the news quite a lot. So variant of interest is just any genetic variant that's been identified, which different healthcare agencies are keeping a close eye on. Variant of concern is any genetic variant which is concerning for either evading current immune system, the current immunity of people, where vaccines may or may not be effective going forward, and also where there's been resistance shown to monoclonal antibody therapy. Finally, we have something called variant of consequence, which fortunately none of the current genetic variants fall under this. And this refers to instances where previously infected people's immunity or vaccines would completely not be able to cover the variant. And this is something which we really want to prevent. And the measures we're taking to prevent that is by genetic surveillance instituted by viral institutes across the world, to keep a close eye on variants of concern to try and curb their spread. So from Delta, there's a new variant, Delta Plus, which has been identified in India within the last 1 month, and it has spread to 12 other countries as well. So something that we're keeping a close eye on. Preliminary reports have shown that this spreads pretty rapidly, but the mortality may not be higher than any of the previous variants. So just a few words about the Delta variant, because it's thought that this is the one that has driven the pandemic to the current proportions in India. So 90% of cases during the second wave in India are from the Delta variant. 20% of cases currently in the US have been attributed to the Delta variant. And this is fueling the third wave in the UK. It is highly transmissible, and there's concern for resistance to several of the existing monoclonal antibody therapies. But fortunately, vaccines still seem to be providing protection against this variant. So I mentioned the third wave briefly. So questions about the third wave. Is India going to have a third wave? Is the world going to see a third wave? And this is a graph from UK showing the beginning of a third wave. So that's something which is very concerning, because they had a similar second peak like how India did and how the US did, seemed to taper off exactly how it did in both of our countries, and now it is rising again. So it is very likely that we're going to see a third wave in India. So this is something that we need to anticipate, and there have been predictions that this is likely to occur around August through October. And the reasons being that there is a very large unvaccinated population in India. Only 4% of the population have been fully vaccinated, and 19% have received 1 dose. One thing that was really nice to hear, especially within the last 24 hours, is to find out that the number of people who have been vaccinated in India has surpassed the US as well, which shows that it's been the public health efforts to ramp up vaccinations are working. So there's hope that we can accelerate the process over the next few months, but it would still be difficult to say that a large enough population will be vaccinated to prevent a third wave. And also prolonged lockdown and social measures, public health measures are just challenging in a country that is so diverse and populated as India. So how do we go about dampening the third wave? What we really need to do is, looking at the first and the second waves that we've had, we really need to focus on measures that will allow us to bring a wave where we saw close to 4 lakh cases in a day, going from that to what we had initially, where we had less than 1 lakh cases in a day. If we can bring this, we would be able to prevent overwhelming the medical system and hopefully curbing complications from the illness, as well as preventing deaths, which was the unfortunate situation in the second wave. So how do we go about preventing COVID-19? And the reason I touch on this first is because this is something which we really need to focus on so that we don't have a similar situation arise again. So talking about vaccines, there are three main types of vaccines that are currently available all across the world. And the principles of these is pretty straightforward. The main final goal is that we want our body to mount an immune system. And this is done against the spike protein of the coronavirus. So the first type of vaccine is a protein-based vaccine. These are the ones that we're really familiar with, where you take a protein, purify it. It's an inactivated protein. There's no risk for infection from this. Injected into the body, mounts an immune system. The second type is where we use a viral vector, where the genetic material that codes for the spike protein is inserted into an innocuous virus. Here it's an adenovirus in the vaccines that we have. This viral vector is injected into the body. The genetic material present within the adenovirus uses the host cell's machinery to produce the protein, and this mounts the immune system response. And then we've got these novel vaccines, the mRNA vaccine, which is something that we all heard about only when talking about the COVID vaccines, is where the mRNA itself is inserted into the body, and the mRNA is then translated into the protein, and then the same immune system reaction is produced. And one thing that has been really inspiring is how rapidly the healthcare system, the medical fraternity, has been able to come up with vaccines that have been made available to the population, and that's something which was unexpected last year. But the fact that we've been able to get effective vaccines is something which is definitely providing hope to us when we're trying to fight against the pandemic. So what are the vaccines that are available right now? Just looking at the vaccines in India and in the US. So in India right now, we've got the Covaxin, which is the indigenously produced vaccine by Bharat Biotech. Then there's Covishield, which is the AstraZeneca vaccine. Sputnik 5 was just recently approved in May. And then in the US, we've got the Pfizer vaccine and the Moderna vaccine, as well as the Johnson & Johnson vaccine, which was briefly halted, but was renewed again in April. The classification of these vaccines, and that's why I've arranged them separately like this. The Covaxin is a purified protein vaccine. The Pfizer and Moderna are mRNA vaccines, and the remainder are all viral vector vaccines. One interesting thing is that the Sputnik 5 vaccine actually has the first and the second dose have two different genetic materials. The thought being that by producing different components of the spike protein, a more robust immune response could be mounted. So next question of who is eligible for the vaccine. So as of now in India, everyone over the age of 18 has now been approved to get the vaccine. In the US, as Dr. Sophia had mentioned, the Pfizer vaccine has been approved for children over the age of 12. Pregnant and lactating women can receive the vaccine. It's just that caution has to be utilized while determining if it is completely safe in them. So the current guidelines say clinical judgment is to be taken into account when providing vaccines to pregnant and lactating women. There have been some studies that showed that when pregnant women received the vaccine, antibodies were passed on to their infants and this was detected after their birth. So there is benefit there as well to give some passive immunity to children who are born to women who are vaccinated. People who have had prior COVID-19 infections can also get the vaccine. The only recommendation is to wait about 2 weeks after symptoms resolve, and in case they've received a monoclonal antibody, to wait 90 days. Immunocompromised individuals can also receive the vaccine. This is something which I feel a lot of us think that, oh, we shouldn't give a vaccine to them, but we need to bear in mind that none of the vaccines are live vaccines. They're not vaccines that have been genetically modified from the original virus itself. All of these are inactivated protein products or genetic material which cannot actually cause the infection. The only thing to bear in mind is that these people have a tendency to mount a poorer immune response. So even if they're vaccinated, they can't lower their guard down with regard to their susceptibility to infection. Contraindications, the strictest contraindications really is if they have an immediate allergic reaction, and over here we mean an anaphylactic reaction. If they have a known allergy to vaccine components, that's another reason to avoid that particular vaccine, although sometimes they can receive an alternate vaccine if this is what has been identified. So what are the benefits of getting the vaccine? Overall, all the vaccines together, I was looking at the data, there's 60 to 80% efficacy against getting the illness. The mRNA vaccines offer about 90 to 95% efficacy. The ones present in India, Covaxin, Covishield, are within the 60 to 80% range. There is reduced severity of illness that's been noticed after getting the vaccine and reduction in hospitalization. And through both of these, there's reduction in mortality as well. And getting the vaccine reduces transmission and decreases viral shedding of the vaccine from infected individuals. So overall, what do we do with this knowledge? So when there is a family that is coming to you, children aren't eligible for vaccines right now in India. But by vaccinating the adult population, parents and grandparents, is how we can protect the children. So that's why encouraging individuals to get vaccines is so important, to try and protect those where we are unable to vaccinate right now. What are the adverse events from vaccines? And this is something which has definitely caused a lot of discussion among the public about whether or not to get the vaccine itself. And the major adverse event which has come to our attention is something called thrombosis with thrombocytopenia syndrome. It's a new condition which has been described specifically for, in relation to the clots that have been seen with certain vaccines. The two where we've had the most reports are the AstraZeneca vaccine or the Covishield, and then the Johnson & Johnson vaccine. And that was one of the reasons why the administration of the vaccine was halted in the US. And the symptoms that could occur from these involve venous thrombosis or mesenteric clots. So they present with headaches, abdominal pain, and the incidence is usually within 4 to 20 days of receiving the vaccine. Could be just one dose, could be 2 doses as well, after the second dose as well. And with Johnson & Johnson, it's just a single dose vaccine. So within 4 to 20 days of getting the first dose. The tests that are recommended is getting platelet counts, imaging to look for the clots, and the management is generally non-heparin anticoagulation. For the most part, the incidence has been pretty low and people have recovered from these adverse events. So that's why the recommendation is still to proceed with vaccination while keeping caution for these for these side effects. Other side effects that have cropped up are myocarditis and pericarditis in adults who have received the mRNA vaccine. And this is under a lot of study, and I'm aware that the cardiology department is looking at a case series as well. So we'll have more data about this in due course of time. So next, looking at transmission and how to prevent the spread of the virus. So this is an animated image over here looking at how droplets and aerosols are spreading from an individual after a violent cough. And the distance that we see over here is about 1 meter. And you can see how without any masking, without any protection, these droplets can spread completely through that 1 meter within a few seconds and also beyond that. So within 3 to 6 feet is usually the range at which a person can inhale droplets and aerosol from an infected individual. Deposition on exposed mucous membranes is another way in which it's transmitted. And another thing to bear in mind is staying in an enclosed space or exposure for greater than 15 minutes to somebody who is sick, regardless of where you are, can increase your risk of getting the infection. So how do we go about preventing the transmission? So the main things which has been discussed quite frequently in the media, as well as what we've received education about, is to wash hands, sanitize hands, socially distance, and the minimum being 6 feet, and also wearing face masks. All of these put together can bring down the transmission by 60 to 80% through different studies that have been done around the world. And this really forms the backbone of preventing transmission and also the backbone of preventing the next wave of the pandemic. We have a lot of new medications and therapies, but really this is where the public health focus should be on. So perhaps around the world, instead of having functions and marriages that look like this, we should be transitioning to something more like this on Zoom. And I saw this really humorous post on social media as well, which is recommending against going on holidays, saying that those of you going on holiday before the third wave arrives, you are likely to contribute to the third wave. So just being cognizant and vigilant about our actions on a day-to-day basis can really help with preventing a third wave from really devastating the healthcare system like how the previous ones have. So now I'm going to talk briefly about how to manage COVID-19 in the outpatient setting. So really focusing on mild infections in adults. And the first thing that I wanted to talk about was the different tests that are available. So there are 3 different tests available for COVID. The first one is a nucleic acid test, which is the PCR test to detect the mRNA virus. And then the second test is the antigen test, which detects viral proteins. And the third one is the serologic test, which detects patient antibodies in blood sample. The first 2 are done using nasal or oral swab to get a sample where we perform the test on. The serologic test is used to detect past infection or response to vaccines. And the antigen test has the advantage of being really rapid, but also we need to bear in mind that it's not as sensitive as the nucleic acid test, so there's a high risk of false negatives. So really the gold standard for diagnosis is the nucleic acid testing. So who do we test and how do we go about testing individuals? Anyone with symptoms should be tested. And the reason being that when there is a global pandemic, the pretest probability of an infection is really high. And as we have seen, pretty much any symptom can, at this point of time, could really be from COVID. The picture here shows all the common symptoms that we're aware of with the respiratory illness, and specifically with COVID, the anosmia, which has been noted in individuals, but really not more than 40 to 60% of people, according to different studies, have really shown anosmia. So we can't say that that's a specific finding either. People can also have chest pain, abdominal pain, diarrhea. Sometimes it's really just some mental fogginess, which could be the reason, which could be a manifestation of COVID. So if there is a suspicion for COVID, the test should be done. But we also need to bear in mind that even with the most sensitive testing, something that's 99% sensitive, you can still have false negatives. And here's a graph showing testing characteristics of of most of the COVID tests that we have, the PCR testing. They're all in the range of 90 to 95, some of them 99% sensitive. But even when there is somebody who has a very high pretest probability of having the infection, if they do have a negative test, say they're 80% chance of having the infection, if they have a negative test, the chance of having the infection is still pretty high and above the threshold of diagnosis. So if a person presents where their disease is acting like COVID, if it's talking, walking like COVID, then that's something that is COVID, and they should be managed as COVID is to be managed. So that being said, we also need to ensure that we don't forget to consider alternate diagnosis, especially with social distancing and decreasing contact with patients. There's a loss in how we do our general history taking and physical examination. And oftentimes, a lot of other conditions do get missed. And I specifically bring this up because just anecdotally over the last few months, there have been several young people who have been tested multiple times for COVID for a prolonged cough, but just because they met different practitioners every time, diagnosis of a mediastinal mass, a lymphoma got missed in some of these people. So it's still important to be able to use our clinical judgment when we're diagnosing COVID patients. So how do we triage COVID once a patient has been diagnosed? So the first thing to really think about is if they're not too sick, and I can go over the different criteria there, but if they're not too sick, to have them stay at home, to wear a mask to isolate themselves. Everyone's got a cell phone these days, so it really is important to maximize the utilization of these resources to protect the individual, their relatives, their neighbors, as well as us as physicians who are here to take care of these patients. And we really need to protect ourselves as well when we're trying to give the best care that we can. But this does give us a way to monitor them and also triage them appropriately. And the only real technology that or other resource that would be useful here is a pulse oximeter. And these are some things which are available pretty easily now because of the increased manufacturing. Of course, the prices can vary quite a bit. But what we've been doing in several of the health systems here is to have a package which includes a pulse oximeter, blood pressure cuff, and also small tablets where the patient can record their symptoms, record their oxygen saturation, and also touch base with a healthcare provider every day just to make sure that things are going on okay and their symptoms still stay in the mild range, and detect early on when somebody would need a higher level of care. So these are the different categories and criteria where we would think of a higher level of care. So with regard to symptoms, if someone's having shortness of breath, that's disabling. And the way in which this can be checked when someone is just talking on the phone is if they have an inability to speak in full sentences. Respiratory rate greater than or equal to 24 breaths per minute. This is also a sign of distress. And oxygen saturation less than 94% on room air at any time, whether they're at rest or whether they're moving around. And how we can assess their tolerance to activity is with the 6-minute walk test, which a person can do in the confines of their home within a single room where they're isolating. And during this 6-minute walk test, if there is a fall in oxygen saturation less than 94%, or if there's a fall of 3 to 5% from the baseline where they start, so say they're at 99% at rest, but with the 6-minute walk test, they drop to 95%, that's still very concerning. And if they develop lightheadedness or worsening dyspnea when they're trying to walk. So these are to be monitored on a daily basis. And if any of these are positive, this would be classified as moderate to severe COVID, and the patient needs to be seen by a healthcare provider and best seen at a hospital with facilities to take care of COVID patients. If it's detected that they need to get admitted, they can get inpatient care expediently. So how do we go about managing mild COVID? So first of all, trying to stay isolated, protect people who are in the house with them, wear a mask, wash hands, sanitize. Symptom management is pretty much like any flu-like illness. So providing antipyretics, paracetamol, making sure there is adequate rest, hydration, nutrition is being maintained. And the recommendations for quarantining at home is at least 10 days from symptom onset, not the testing, but the symptoms being found to be present, and at least 24 hours without any fever or chills. And the reasoning behind this is that several studies have shown that viral shedding decreases by day 9 to 8 of being diagnosed. And monitoring for worsening clinical status is very important to note that the critical period of deterioration tends to be between days 7 to 10, which is when respiratory distress has been noted to be setting in. And again, reiterating on social distancing, washing hands, and wearing a mask. Next, I wanted to talk briefly about the role of imaging in diagnosis of COVID-19. And it does seem that almost everybody seems to get a CT scan because there were initial reports saying that CT can be used for diagnosis. But really the recommendations, and these are guidelines that have looked at from Ministry of Health and Family Welfare as well as the NIH guidelines, which state that really only moderate to severe cases should get a CT scan. And these are also done only when there's clinical deterioration despite recommended inpatient therapy when the patient's on oxygen, and also after they've received things like remdesivir and steroids. And the reason this is usually being done is to look for invasive fungal infection. Clinical judgment of a specialist is definitely something to take into account when certain instances like suspicion for a pulmonary embolism would be another indication to get a CT, except with an angiogram to rule out clots if somebody were to become more hypoxic than what is expected. And the reason why we would like to limit CT scans, and some of these which I will enumerate now, is that findings are noted in 2/3 of people who are asymptomatic, and the imaging findings are the ones that you see here on the corner of the screen, where there are diffuse bilateral ground glass opacities, and these can be present throughout the lungs. And in the lower half of the image, you see how they've progressed with some extra edema as well. And you can see an ARDS picture, even or something similar to that with patchy infiltrates, even early on in the infection in people who are asymptomatic, where there's no progression of the disease. They may recover, and finding this information can just cause unnecessary anxiety, hospitalization, where the benefit of it really is not outweighing the risks of the CT itself. Early CTs may actually be falsely reassuring. So again, getting it early on, having a negative CT could make somebody feel like they're not at high risk for a severe disease. So if they do develop shortness of breath, say on day 7 or 8 of their illness, they may feel that things are not that bad because their CT was okay. And similarly, physicians may also feel falsely reassured. There's also a variable correlation between the amount of lung involvement and the level of hypoxia, which is noted. This correlation is mostly discordant because of different age groups. So younger individuals have a robust immune system. They may have more lung findings, but they're not as hypoxic, not as sick, and they recover much better. Whereas older individuals may not have as many findings on the lung, but they do become pretty hypoxic and they can have complications from it. So having an arbitrary cutoff of a certain percentage of lung being involved being a reason for admission may miss a lot of people who are actually much sicker. So really, we should be going by the level of hypoxia and oxygen saturation when triaging individuals. Several of these lesions persist during recovery as well. And of course, there's a radiation risk from CT. So outpatient therapy, and I'm starting with what not to do because there's just so many studies, so many things in the media looking at several different therapies. And a lot of therapies which have been approved for inpatient use, which there's always a question of how do we use this in the outpatient setting and if they should be used at all. So the first one being remdesivir. So this is an antiviral agent which is only indicated if a person is hospitalized, if they're on oxygen, and it should be given within 10 days of symptom onset. Now, it is true that there are a lot of people who are being managed with oxygen at home. So those could be exceptions where remdesivir could be considered. And this is given as an IV infusion. So you do need a facility where you can provide the medication as well. Tocilizumab is an anti-IL-6 antibody. It has been used in rheumatoid arthritis as an immunomodulator, and it gained a lot of popularity in initial stages in critically ill patients with COVID. And really, the indication is only in critically ill patients where there's no improvement with oxygen, and when the patient is noted to have high inflammatory markers like high CRP, and also IL-6s as well as tested. And there is some mortality benefit from doing this, but not in anyone in the outpatient setting. Steroids, as Dr. Sophia had also mentioned before, there is mortality benefit in people who are on oxygen, but there are so many risk factors associated with steroids to keep in mind. It is harmful in mild cases. It prolongs viral shedding, so it increases transmission risk. And it also leads to immunosuppression in patients who may otherwise have been doing okay with fighting the virus themselves. And as everyone is aware of, steroids do cause alteration in blood glucose levels as well. And this has been thought to be driving the associated epidemic in India of mucormycosis as well, which has been causing a lot of mortality. So it's important to bear in mind and limit the use of steroids. Anticoagulation, again, not indicated in the outpatient setting. It's only for moderate to severe disease. And when someone is hospitalized, there are a lot of recommendations to triage individuals based on the D-dimer level to figure out whom to anticoagulate. And also a final word on antibiotics, ivermectin, hydroxychloroquine. These are all things which have popped up in the past with thoughts about some benefit, but none of the studies that have been done so far have shown any evidence of benefit in adults. On their own, if there is a reason for indication, antibiotics are definitely recommended if there's suspicion for a bacterial infection. But for the most part, when someone comes in with COVID, it usually is just isolated COVID, unless they're at risk or immunosuppressed and you're suspicious of an infection as well. So I wanted to talk about monoclonal antibodies and plasma. And here's a image showing how monoclonal antibodies are thought to be useful. So when we're able to inject an individual with antibodies that act against the spike protein, The idea is that this prevents the binding of the spike protein to the ACE receptors on the human cell. So thereby you can decrease the chances of infection itself in the individual. The indications for these are in high-risk individuals, and there is an emergency use authorization which has been approved in the US as well as in India, and determining these, explaining who these individuals are. So anyone who's obese with a BMI over the age of 35, age over 65 years, someone with chronic kidney disease, with diabetes type 1 and type 2, if they're immunocompromised, and also if they're over the age of 55 but have cardiovascular disease, hypertension, COPD. This does end up capturing quite a large population around the world. So there are a lot of people who could benefit from these monoclonal antibodies. In children, there is not as much data, but over the age of 12, among these categories, it is considered, it can be considered children with BMI over the 85th percentile for their age and gender. Sickle cell disease, if they have a heart disease, neurodevelopmental disorder, or if they have asthma or reactive airway disease, this is something that can be considered in a monitored setting. A lot of the time it's encouraged that people who are getting these enroll in a trial so that we can get more data about these treatments. These are not indicated in people who are, these are only indicated in people who are not hospitalized. And if they're hospitalized, it should be for something other than COVID itself, without any additional oxygen requirement. So what are the antibodies that are available right now to us? Most of these are an alphabet soup, really. It's difficult to really say all of these names. But the earliest one that was approved was bamlanivimab and etesevimab, marketed in India by Eli Lilly. And then the second one is kesirivimab and imdevimab, which is marketed in India by Roche. And there's a trial in UK as well, where it's called Region COVID-2. And then the third one is sotrivimab, which is the newest one, which is not available in India at the moment. All of these are given as single IV infusions, but subcutaneous administration is also permitted. They're to be given within 10 days of symptom onset. And it's okay to use if someone has been previously vaccinated. It's also okay to use in pregnancy and lactation if they have one of the indications mentioned previously. And it can be used in children as well if it's indicated. One thing to bear in mind is if someone's received these antibiotics, it's important to wait 90 days before vaccinating them. Now, unfortunately, there is resistance to bamlanivimab that's developed across several of the new COVID variants. So, in fact, this is actually the bamlanivimab has now, it's not permitted to be used in the US anymore because of risk of resistance, and how it may not be helpful to even give it in patients. So that really leaves us with the second combination of monoclonal antibodies. And I wanted to quickly summarize some of the data we have from clinical trials. Things to bear in mind is that only 2 are in phase 3 trials right now. And peer review is not complete for any of these. There's no published data that we have. But the preliminary results show that there's a 2 to 5% absolute risk reduction in hospitalization or death through the first 28 days after getting these antibodies. And there is a 70% relative risk reduction. And how this data is really received is that the trial that looked at the Region COVID-2 showed that 1.3% of individuals in the trial population had a reduction in hospitalization or death, and this was taken as a composite outcome, versus 4.6% incidence in those receiving the placebo. So doing some quick mathematics there, it shows that the number needed to treat is 30, which means that 30 people have to get this monoclonal antibody, and 30%, and this will be 30 people in the high risk group should get this before one person shows benefit. So difficult to really say if how feasible this would be or how useful this would be. And there are side effects of anaphylaxis and infusion reactions. So I would say slightly ambiguous about how excited we should be about monoclonal antibodies, but it is something definitely to bear in mind as an option to treat people with mild infection. A brief word about recovery from mild COVID-19. The fortunate thing to bear in mind is that 80% of cases tend to have mild COVID-19, and most of them recover completely. viral shedding diminishes within 10 days, so they can stop quarantine after 10 days. But things which are currently evolving is that there is concern for something called a post-COVID-19 syndrome or a long hauler syndrome. And this is a combination of symptoms which include fatigue, brain fog, just a feeling of listlessness, which seems to be persisting for several months after recovery from COVID. And right now, there are several specialists in general internal medicine who are setting up a clinic to try and assess these patients and provide therapy for them. And a lot of the management is really geared towards managing the symptoms of fatigue, and the approach to it is very similar to management of fibromyalgia. So it's really a systemic approach with conservative management, no specific medication so far, but just physical therapy as well as psychotherapy sometimes to help with coping with these symptoms. There have been several studies, case reports that show there's been damage to the heart, lungs, the brain, and there can be prolonged recovery from these, especially with more complicated illnesses. But sometimes even with mild illnesses, several months down the line, somebody might have myocarditis or have demonstration of an increased susceptibility to small insults to the lung. And these are things which are still evolving. So really only time will tell how people do after recovery. As we all know, we only have data from about 1.5 years right now. So over the years, we'll find out more information. So to summarize quickly about what was just discussed, and just going over things and some questions that we could get asked by our patients as well as their relatives. Is COVID-19 coming to an end? Not really in the foreseeable future. We need to accept that this is something that's going to stay with us for the next months to years, and we need to be prepared for a third wave as well, mostly driven by COVID-19 variants. When should we test individuals? Really, if there's any suspicion of infection or exposure, and we also need to be wary of false negatives and be cognizant that if someone looks like they have COVID, they should get the management that they need. Who should be vaccinated? Everyone over 18 years of age, and quite literally anyone who becomes eligible. So when it opens up to younger individuals, they should be vaccinated as well. How do we prevent transmission? Again, reiterating hand washing, social distancing, as well as wearing masks. Outpatient management of COVID-19, mostly conservative management, supportive care, using telehealth and amassing resources that are available right now in this day and age to prevent exposure and protect healthcare workers as well, where we can effectively monitor, triage them so that we can give care and optimize care to people who need it the most, and avoiding treatments with limited benefit. And finally, on monoclonal antibodies, there is benefit in people with high risk, but there's also concern for resistance. So that's something to keep in mind. So these are the references that I used while preparing these slides. And topics for further discussion are inpatient management of COVID-19, insulin resistance during and after COVID-19, which is something that was brought up in the previous discussion as well, and also more information on the post-COVID-19 syndrome, because after so many people who have been infected, this is something which is probably going to be the next thing that we will have to tackle in the years to come. And so finally, wanted to conclude by expressing my gratitude for being given this opportunity to speak to everybody here. This has been really educational for me, going over the current literature and current information that we have. And I think one thing to bear in mind is that it would be really nice if we had a quick fix for this problem, but none of us are really heroes in this situation, but we can do a small bit by educating ourselves as well as carrying out public health measures to prevent the spread of COVID. So thank you, everybody, and hoping that everybody has a good evening and good night.
Thank you, Snega, for your excellent deliberations on COVID. And your flow was excellent. And although you said first talk, it looks like an expert speaking on COVID. Thank you very much. You will have a great future. We have quickly, before going to SBS for the expert comment, we'll quickly 1 or 2 questions. Before that, I have a strong feeling Okay, 1 minute. Okay. So, 1 minute. Congrats. Okay, lucid presentation. Any self-testing facilities available in USA? We have rat in India. I don't know. I don't have experience. It can be done at home. You have any experience in? It's available in USA.
No, it's all
I
state provided, state testing. It's no, like Amazon, eBay. It's no.
Okay, make contact. Okay, pandemic, COVID. Somebody has asked, is Covaxin accepted in USA? It's not accepted. I don't know. Somebody said you have allowed not to wear. I mean, discontinued wearing mask, isn't it?
Yeah, CDC actually has lifted the like a mask mandate, but individual states, facilities have their own policies.
Okay.
So we are kind of greatly divided between Democrats and like Republicans. So some of these states are pro and some are anti. But like the state where I live is like main hospitals, institutions, local stores, they have their own policies. So basically, what they said was vaccinated people can remove their masks, but how will I know who is vaccinated and who's not vaccinated? So I would recommend everyone, like all my colleagues here, the parents and their children, I strongly recommend wearing masks, because as I mentioned earlier, even though it is 90% effectiveness, right? It leaves the 10%. No one knows who will respond and who won't respond to the vaccine first. Second is, even within vaccination, from an individual to individual, the vaccine response is going to be different. Some can be robust, some nothing. Unless we test for neutralizing antibodies, it's going to be difficult to say who has mounted a good response. So vaccination is not, it's not equal to, like I'm free from, or, like I'm immortal. No. So we should still maintain all this social measures, one, to prevent ourselves, and then also to, like make sure that we don't harbor infection and pass it on to vulnerable people at home. And also, like we take care of kids with several problems. So I don't want to be a source to pass it on to my lung patients. So I think it lies with each and every individual.
Okay, thank you, Sophia. But I don't know why this CDC is some other forces compelled CDC to because somebody WHO CDC is giving guidelines every day. ICMR is giving guideline. Government of India is giving guideline. Okay, another day with Priya Sambatkumar from your hospital, I think, and Soumya Swaminathan from WHO were discussing in a TV show. They said there is no role for remdesivir. Okay. Another thing is there is no role for CT for diagnosis of or any complication regarding COVID. If you want to have some doubt about COVID, some other illness, say maybe some tuberculosis, then you do CT. Otherwise, they said absolutely there is no. It is I don't know whether it is. I think Priya is from your hospital.
Yes, she is adult ID. I am pediatric pulmonology. So in our hospitals, and like most of the hospitals, ID folks play a major role in creating guidelines and policies. I mean, especially with pandemic, like we don't want to misuse or overuse or abuse what is available. So usually we have guidelines. So Priya Sampat Kumar is actually adult ID.
Okay. So I think we'll get some more question. We'll at the end of the after expert opinion from our sir, Dr. SBS, we'll take some more question if time is available. Sir, over to Dr. SBS, sir, for your expert comment.
Thank you, Dr. Guna Singh. I'm just wondering whether I should give any comments at all. The two sessions have been absolutely brilliant. First, of course, I'm very proud that Dr. Sophie Pillai, an alumnus of KKCDS, has delivered a wonderful lecture. Thank you, Dr. Sophie. Second,
thank you, sir.
I'm very proud that the gene is there in Sneha, that of Dr. Yamuna, and of course, my guru, neonatologist Dr. Gopal. who's her uncle. God bless you. It was brilliant, outstanding. I don't know whether I should say anything except those 2 sessions were marvelous with a lot of clarity and very good messages. Thank you both. But Guna Singh will not be satisfied if I don't take at least 5 minutes to say something. First, with reference to what Dr. Sophie said, I saw in her slide in US, respiratory manifestations are the most common manifestations of pediatric COVID. Dr. Sophie, in our own hospital, we have had more children with GA manifestations than respiratory manifestations with COVID. And this has been the observation in India, which is quite different from China and US. So even if there is vomiting and diarrhea, one has to think of COVID. Of course, Dr. Sneha very rightly said, any symptom you think of COVID. But the caution here is,
Sir.
COVID, yeah?
Thank you. அப்படியா சரி நான் அவர் எப்படி ஓகே ஓகே.
The caution here is that COVID may be a bystander with so many other tropical illnesses and routine illnesses in children. That was, of course, pointed out. Second is, Dr. Sophie mentioned that they are seeing a lot of severe COVID in children with comorbidities. Dr. Sophie, interestingly, in KKCTH over the last 15 months, we have found that these children with comorbidities have done probably better than normal children. In fact, we are trying to get it published. In comorbid children, the disease is much more mild than in normal children. I don't know how to explain that. That is an interesting observation we have made. Third, you said that asthma is quite commonly associated. Dr. Guna Singh and others would agree. I think wheeze has gone off from the community. There is hardly any child coming with acute wheezing. In the last 1 year, I don't know whether it is because of the absence of schooling or because of masking. Very few acute asthma episodes have occurred. At least in our hospital, I can tell you, it has come down drastically. No RSV at all, hardly any RSV. There is no infant wheeze. Everything has disappeared and robbing the pediatricians of their rightful income. Well, good for them. And the other observation I thought I will share is that in Miss C, in India, we have had more children between 0 to 5 years, much more than in the United States or in Europe. I don't know the reasons, but this is one observation which has been made. I'm very happy to note Sophie mentioned the mortality of Miss C is around 1.9%. I was very disturbed when I saw a paper from Safdarjung Hospital quoting a mortality of 20%. 20%. Fortunately, in KKCTH, I'm happy to tell you, we have had 145 cases of Miss C or PIMS TS, 0 mortality, touch wood, until today. That's good news. And the other thing which I don't know, Dr. Sophie mentioned, co-infections have been there in 20%. Is that really true, Dr. Sophie? Because most literature reports say that the co-infections are very, very rare in pediatrics, and it is only to the tune of 5%. I heard you saying 20%. Can Dr. Sophie clarify at the end? And one thing, because our own observations are that co-infections are exceedingly rare. And of course, with regard to Dr. Sneha's lecture, she mentioned that we can prevent with hand washing and social distancing and other measures. But I don't know how it is possible in our country like India. You know, even if somebody is infected, where are the rooms for them to self-isolate? That's a problem. So I think for India, vaccine is probably the best solution. Of course, along with masking and hand washing. Overcrowding is something which you can't get away with in India. And she rightly pointed out testing should be done. At the same time, negative testing should not be taken lightly. In fact, a child who's ill and who's negative might have MIS-C or might have some other infection or still COVID-19. So you cannot get misguided by the negative test. The other point which I wanted to stress again, CT scan should be replaced by good clinical judgment. Dr. Guna Singh knows, Dr. Sneha, I am to tell you that in some government portals, doctors have to upload CT scan reports. You know, the reason is that every adult in India, almost 90 to 95%, gets a CT scan done the moment the PCR or the rapid antigen test is positive. You rightly pointed out doing it very early is a waste. Don't treat the CT, treat the clinical picture. The other interesting observation I want to make is regarding the long COVID. I think long COVID, I was surprised to read an article from Italy. I believe even in pediatric COVID, long COVID could be there in 20%. But I can say from personal experience, long COVID in pediatrics is mostly psychological. Physiologically, nothing much is happening in children, unlike adults. Of course, adults, yes, it is there, it will be there. Last but not the least, Dr. Sneha mentioned that monoclonal antibodies may not benefit much. But I think with this Delta Plus, which is going to cause havoc, I'm sure we will find maybe by next year a good monoclonal antibody which is safe, which is probably given on day one of illness might prevent complications. These are my comments. I again congratulate both the speakers for conveying very effective messages to Indians. Thank you very much. Thank you, Dr. Guna Singh.
Thank you
for your comments. Before going to the discussion, Sophia and Snega, and we, on behalf of IAP Tiruvannamalai branch and IAP TNSE, we welcome our senior most pediatrician, our guru, Dr. B.R. Nammalwar sir, to this forum, and bless the young speakers. Over to Dr. B.R.
Thank you, Guna Singh. Guna, I call you. Thank you very much. You're always considerate to me. I'm so happy to, I think it's one of my best happy days in my life, listen to my old friend, Dr. Sophia. I still remember going to her house with a small having food, with, having a dinner with my wife and myself. And Dr. Sneha Mohan, I'm so happy that you are carrying the gene of Dr. Gopal, an excellent neonatologist, a man with discipline, who held the principles was the right thing. I'm so happy to hear both of you. What lovely talk. It's a really lovely talk. Of course, I missed Sophia's a little earlier because something was wrong with me. But I really enjoyed myself. More importantly, I'm so happy to see both of you. God bless you. God bless Guna. God bless Dr. Bala. As all of you, all the young people, because I think that's the only way I can thank all of you.
Thank you, sir.
Thank you. Before going to the next session, 1 minute, Dr. Sir, Srinivasa sir.
Already I congratulated Gopal by ringing up, and of course I don't have Yamuna's phone number, though I know her so well. So both of you have done a wonderful job and so much of confidence and very clear presentation. So all the best in your
career, and I'm sure you are all going to have a very bright future. And you have been blessed by so many people, Dr. Namalwar, Dr. Balasubramanyam, and Janani, who all trained you. And excellent. Yeah. No words to describe my happiness to have listened to both of you today. Thank you.
Thank you, sir. Thank you.
I thank Guna Singh also for
Thank you.
inviting me to participate, and I got the Ismail has sent me the link. Thank you so much.
Thank you. Emma, Sophia, and this one important thing is in India, somebody asked the vaccine efficacy is very low, especially in the second wave. So many people, my relatives, all got infected, both two doses. Maybe the mortality is less and the admission ICU. Is it the protective efficacy, vaccine efficacy is low? Whether I have a very serious doubt in this second wave, whether this vaccine is going to prevent COVID at all. Your comment, even from SBS also.
So what, the vaccine efficacy, what they test in the lab versus out in the real world, there are two different things. So again, the vaccines, as of date, what we know is it definitely gives you a mortality benefit. That means I'm not going to get severe COVID. That much is very sure. But nobody knows how effective it is in preventing reinfections, because we're already seeing breakthrough infections with even in people who have who had 2 vaccine doses and 6 to 8 weeks out of the last vaccine. So for sure, as I mentioned, severe COVID will be that benefit is there, but reinfections are going to happen, and none of us know how long each of us are going to maintain this immunity. So it can be 3 months, it can be 6 months, it can be 9 months, or even up to 12 months. That's why they say we are going to have booster doses every year. So it's still, evolving science. So we don't know, but for sure it gives you mortality and immunity to severe COVID infections.
Sir, SBS, sir?
Yeah, just in fact, strange. Only this evening, I saw an announcement by AstraZeneca. I believe they have conducted one trial by giving the second dose 10 to 12 months after the first dose, and the antibody titers are much higher than doses given at 0 and 3 months. So we never know what is going to happen to the future of vaccination with COVID-19. We have had very short time after administration of the vaccine. It is too early to say and dump these vaccines. It's wrong to say these vaccines are useless. If you see the UK, US data, vaccines have done wonders. They are likely to be effective. And of course, we have had instances where we have seen many doctors succumbing to illness after 2 doses of either Covishield or Covaxin. Nobody is denying that. The only way we can save this world from this deadly disease is vaccination, vaccination, and vaccination. And the perfect vaccine is still not yet known. And this may also go the influenza way, where we'll be taking vaccine every year. In fact, there are again interesting studies of interchanging of vaccines showing better immunity, better efficacy. So it's still a long way to go. Until then, we should not allow the anti-vaccine lobby to take the upper hand like Republicans in the US. They should not be allowed to, what I feel, the vaccination drive should never be toppled. It should go on. In fact, if the third wave is going to occur, we should protect our children by vaccinating more adults as early as possible. Until the vaccine gets approval for below 18 years, the only way, the best way to protect children is by vaccinating as many adults as possible, as fast as possible, so that if the schools reopen, we have to open the school sometime or other. These children don't suffer from COVID.
So thank you, sir. Sophia, in US, is reinfection is quite common with Moderna vaccine also.
Yes, sir. We are, like, I don't have the statistics with me, but there are reinfections or what we call as breakthrough infections, even in people who have received the vaccine. But again, as I said, like not the whole country. Almost, I think 50% of us is vaccinated, and many actually have received the second dose. So like we will have more information, but some reinfections are common.
So I have one comment. I think in 1985 and Rajiv Gandhi birthday or something, the universal immunization program is started to cover 6 diseases. Even after 35 years, isn't it? 35 years, we have reached only 60% all India level. In Tamil Nadu, it is almost more than 99%. South India is doing better. In Arunachal, it is 35% still after 35 years. I have a very serious doubt about the vaccine will control COVID in India, because there is a lot of hesitancy. In my hospital, 85% of the sisters didn't take vaccine. Some doctors also still hesitant to take vaccine. I don't know. So some other is what is the masking rules in children in India? They have government of India says above 5 years mask is a must. In US, what is the guideline?
So we say age appropriate. So, like the children who come to see me in clinic, I once saw a 1.5-year-old, 18-month-old. The father and mother, both of them are nurses. They wear masks. The child came to the clinic with the mask, was wearing a mask throughout. So we have child appropriate masks, not the adult mask because it won't stay. So we have small masks. And the child was wearing the mask. And at the end, like when he was saying bye-bye to me, he pulled the mask down. I could see the pacifier in his mouth. So it's not that children will not wear a mask. If they see the parents wear a mask consistently, the children is going to remind the parents to say wear a mask. I mean, there are some kids with sensory issues like autistic kids where they don't like anything on their face. So it is difficult for them to wear a mask. But as I said, when it's age appropriate, if they can wear a mask, please wear a mask. So coming back to Dr. Balasubramaniam's 5 questions, I'm just going to be very brief. So you talked about the comorbid kids with comorbidity who seem to fare very well. Again, this boils down to viral load or viral inoculum. So if I know that I already have a predisposing condition, I'm going to be extremely very careful. So I'm going to consistently wear a mask. I'm not going to expose myself to strangers whom I don't know. I'm going to have, practice all social distancing, safe, like hand washing, all those things. So again, it boils down to the amount of virus particles that enters my system. So if it's only 5 versus, like 500 or a million, I'm going to, like fly through it. So that is what we are seeing. And as I said, kids with CF, like cystic fibrosis kids are, like the notorious ones. There, we didn't see, like any of these bad exacerbations. So that's your first question, sir. So the second you said, like about wheezing, you didn't see any respiratory illness. And we also, the trend in US also was the same, because again, we all know that all these transmissions happen because, in winter, when they're close together, airborne, respiratory, like droplets. So when children were, kept at home from school, so the rates of all this infectious, like the seasonal infections went way down. We didn't have any kids come in with asthma because of asthma exacerbations due to viral exacerbations. That's what we saw so far. But then there is a second, like a story to that. So now with schools reopening, what has happened is, we are seeing very bad RSV, very bad rhinoenterovirus. And then the theory behind that is, as long as I'm exposed to all these viruses, I'm going to have my adaptive immunity, which is lost when I was kind of sheltered for 18 months. So I have seen kids, like now in my hospital, like I've never been to the hospital, was coming with status asthmaticus with rhinoenteroviruses. So we really need to be careful. The coming, like fall and winter, these viruses are going to take a major toll. Again, we need to, there is no doubt that the mask measures is going to, help us. And then the third I wanted to say is, like I talked about the virulence. And then the fourth, the missy mortality. So, I mean, again, like the missy mortality could be, like different depending on where we get the information from. It boils down to early diagnosis, because these kids have more profound cardiac involvement, so they're in shock, or like all those things. If not addressed early or monitored, so then your morbidity, mortality is going to be very high. And then the fifth, about the co-infections, like maybe it's an old paper, but like I remember it was 18% for sure. So I'm going to get back to you on that. I don't have statistics just to share with you right away. And then long COVID, as you mentioned, Dr. Balasubramaniam said, we are actually seeing both physical and mental health issues, especially in teenagers. We are seeing a lot of mental health issues because, they need to be with their friends. And then even in children, we are seeing, developmental issues, especially in babies who are in the NICU. There, they have to stay there because, they're having the 24/7 ventilatory requirements. We saw that, when we were masking, their child development was actually delayed. The moment we changed, now we have changed to the clear mask. So the clear mask is, where the mouth is kind of, kept clear. So this we use for our own colleagues or residents who are, do lip reading. So we have been doing this. So now all the NICU, the neonatal intensive care, when we are rounding, we actually have the clear mask where the children can actually see the mouth. So that has shown that their development is also impacted because of this mask wearing. I think I have answered all your questions.
Yeah. Dr. Gunasingh, incidentally, I saw one question in the chat box on TB and Missy. Because Sophie and Sneha would be the last persons to talk about TB and Missy. They won't be seeing case at all. From our observations in child stress, actually, what we have seen is that the number of newly diagnosed TB cases in the last 1 year has not come down. It's almost as much as it was a year back. But that doesn't tell us anything, because TB is a disease which has got a long incubation period. TB has got a peculiarity of having a latent period which is variable with regard to the system involved. We never know when these children picked up infection, but it is predicted if universal masking is going to continue for long, particularly in a country like India, where spitting is a sport and pastime for majority. Wearing a mask certainly will reduce transmission of tuberculosis in the long run, though there are immunologists and microbiologists who are saying COVID-19 could well suppress the T cell response to TB and exacerbate underlying TB, but very little data is as yet available in literature. I don't think we are going to get more TB because of COVID-19. That's not likely to happen. Somebody had asked about early antibiotics in COVID-19. I don't think there is any place for early antibiotics in COVID-19. Early antibiotics are required only if you clinically or with investigations diagnose a bacterial infection. And I'm convinced that bacterial infections, super infections are extremely rare in pediatric COVID. So we don't have to give antibiotics routinely. The problem is there only in MIS-C. MIS-C can mimic, any bacterial sepsis. So we have to be careful. The threshold for antibiotics in a critically ill child with suspected MIS-C should be very low. The threshold for giving antibiotics to somebody with mild or moderate COVID who doesn't have clinical or laboratory features suggestive of bacterial infection, our threshold should be high.
Okay, thank you. I think Dr. Somashekhar, last question. I think roll up Anakira IL-1. Do you use?
So in pediatrics, as I said, I have not seen these, as I said, it's all case by case. It doesn't come to my mind. I had one kid who came in with severe COVID, ARDS, and developed pulmonary aneurysms, which was, rare. It's not even in adults they have reported. So that kid had remdesivir within that, the 10-day mark period. I don't remember. There was another Missy kid who had plasma exchange IVIG. I don't remember Toxi or, Anakinra being used. So I don't know.
Dr. Gunasingh,
Yeah.
I've not seen it being used in adults either. Just the tocilizumab has been used before, another IL-6 antagonist, but not the IL-1.
Okay, Sneha and Dr. Sophie, in child stress, we have had, I said, 145 and odd cases of MESI. We have used tocilizumab in 3 children. And last week, we gave anakinra to a child who had refractory MESI with excellent results. It was almost dramatic. Anakinra, we got it airlifted from Bangalore. It's not available routinely in India. So somebody had got imported stocks. We got it airlifted. It came within 12 hours. We gave 2 doses, magic bullet. Next day, child became afebrile. 48 hours, the CRP from 150 came down to 7. This child had right ventricular diastolic dysfunction with cardiac failure. Child came around. Similarly, tocilizumab we have used in 3 children who did not respond to IVIG plus high-dose steroids. In fact, we published our first case also. This is the worldwide. This is the first case of hyperinflammatory syndrome which was treated with tocilizumab. But now tocilizumab is out of stock. So now today in India, anakinra is cheaper to get than tocilizumab. Tocilizumab costs around 1.5 to 2 lakhs in black market. It is very difficult to get from the government side. And in terms of the comparison between anakinra and tocilizumab, anakinra is preferable because the risk of infections is far less with anakinra than with tocilizumab. The side effect profile of tocilizumab is much worse than anakinra. Anakinra is better. If it is widely available, it may become the first line of treatment for refractory MESI or KD.
Thank you. I think one more comment, Ma. This mucormycosis is very common in India. What about you in US, Sneha? Any comments on that?
I would say personally, I haven't seen a patient with mucormycosis. And I think it may have to do with just the epidemiology of the fungus itself.
Maybe
and how prevalent that is.
Overuse of steroid in Indian continent, or
could be a component of it. And that was something which I remember Dr. Jayakumar had also brought up about diabetes and insulin resistance. And quick comment about that is in India, the prevalence of insulin resistance, metabolic syndrome is so high, and a lot of people are undiagnosed as well. And steroids are easily available. So I feel like that the combination of undiagnosed metabolic syndrome as well as steroid use in the outpatient setting could be driving it. But I'm not personally aware from my experience about how things have been here in the US, because I think it's not been reported much. And I did look to see if there were some incidences of mucormycosis. It's only a few case reports scattered across US and UK combined.
Yeah, I completely agree with Sneha, because like all this fungus, like they live around us. So as she mentioned, like many of us are pre-diabetic one, and then injudicious and long, like durations of steroid is going to add to the fuel. And the other thing is, like whenever I have humidification system which is not set up right, or ventilator circuits which are not set up right, because these are the places where we can have rampant fungal infections. And if I'm at the hospital, my immune system is anyway going to be not like optimal. So all these things add fuel. In the US, typically I have seen mucor is like deadly. It's invasive usually in children who are very immunocompromised after solid organ transplants on immunosuppressive medications, but not otherwise.
Thank you, Ma. So with if there are, I think, no question, I think we will conclude this session. I have a feeling that next, if at all, if next wave is going to come, 50% of the drugs using now, it will go out of the market. I have the feeling, because I have this is during the second wave, I'm really worried about the drugs rather than COVID infection. We can escape from the infection, but not from adverse effect of drugs. That's what I am really worried. All experimental drug used on humans, like guinea pigs. That's really worried. Hope the third wave will be controlled. We all will be safe. Hope to visit all Sophia and Sneha Morgan in Mayo Clinic one day or other. Yeah. Sophia.
So first of all, I need to thank you, all of you. And it's a special blessing to see Dr. B.R. Namalwar on screen. Sir, vanakkam, sir. It's always, like training from, as Dr. Balasubramanian said, all, like they molded me into a good pediatrician for what I am today. And then going back to Dr. Jayakumar's sir on the diabetes, I had put that slide up, that severe COVID. So the reasons for, like why type 1 diabetes seems to be, like at a higher risk or predisposes you to is, like one, they say poor glycemic control, as I mentioned, and also complications due to the poorly controlled diabetes even before I had COVID. And then the third is, like new onset diabetes with COVID, which, like then, like delays diagnosis, delays treatment, all those things adds to the morbidity. And I think that's probably the reason why type 1 diabetes, like seems to be, like the top risk factor or predisposition for severe COVID.
Okay, thanks. I'm really worried about the rational antibiotic therapy during COVID. Already, I think we are fighting rational antibiotic therapy, another thing. I don't know, nobody nowadays talking about rational antibiotic in COVID, especially. Hope we'll all be rational in treating COVID infection and other things. So once again, I thank you. Before we say bye-bye, can I have Yamuna on the screen just to show the proud mother? Yamuna, you are on? Yamuna, say bye.
Coming, sir. I'm coming. Yeah.
Yeah. Okay.
Hi. It's really a proud moment. And I'm very, very thankful to Professor Gunasingh for arranging this. And the inspiration has been Dr. Priya Sampath Kumar and Dr. Vincent Rajkumar from Mayo Clinic, who have been contributing to the management of COVID in India through the media. And he was Professor Gunasingh immediately called me and said that Sneha is in Mayo. Will she be able to organize speakers from Mayo Clinic, and will she be able to talk on the topic? I said, you should contact her, sir. And he emailed her, and it's fortunate that Sneha was able to accept and she could do this. And to have Professor Namalwar, Professor Gopal, Dr. Balasubramaniam, Professor Gunasingh, Professor Somashekha, and so many of my teachers and Professor Tangavelu, Dr. PRC, they're all been, they know me as a student from third year. And now to see, in fact, they've all seen Sneha as a baby. And to get all your blessings on this day on little Sneha is really overwhelming. Thank you, Professor Gunasingh. Thank you, all of you, for all your kind words. Thank you so much.
So good night to our friends at India, and good morning to Sneha and Sophia. Bye-bye. We will see you again in another meeting. Thank you, sir.
Sure. Thank you.
Thank you very much.
Bye-bye.
Thank you, Sophia.
Thanks, Dr. BRN. ரொம்ப
you
சந்தோஷம் சார்.
volunteer.
உங்களை பார்த்து ரொம்ப சந்தோஷம் சார். I'm so happy to see you. Right. You're keeping good health.
Yes,
நான்
ma,
அடுத்த
doing-
தடவை சென்னை வரும்போது வந்து பார்க்கறேன் சார்.
Yes, ma. I miss you.
Definitely. Thank you, sir. Of course வந்து பார்க்கறேன் சார். உங்களுக்கு திருப்பி நான் சாப்பாடுலாம் கொடுக்கணும்ல. I tested you long time ago when I was young and naive, but I'm a good cook now. பார்க்கலாம் சார். Take good care of yourself. The Gunasingh sir, ரொம்ப thanks. You're the Sachin Tendulkar of IAP.
Nothing like that, ma. I just wanted you people to talk and what is happening in Mayo Clinic. Just wanted to know because I'm really during the second this one I'm really worried. Many friends, I think you all know our friend Dr. Nagaraju and so many classmates are. I think the mortality is very, very high, 3 times or 4 times. We must have touched 1 crore now. I think 10 million death. We are showing very low death. Very, very. I know somebody, some Marapur Ekam or somebody from Tamil Nadu has raised the issue because it is 4 or 5 times. Death rate is very high. How can it be during the COVID? Say compared. Okay. So
yeah,
I think we should be safe. Okay. I don't
Very
know.
disheartening, sir.
Okay.
Blessing.
Yeah.
Congrats, and Dr. Vindhyarani here.
Oh,
I
oh,
wrote a comment. I couldn't write my name and all. And both Sophia and Sneha, excellent presentation. My blessings.
Thank you.
And may God bless them, both of you. I know they
Thank you,
have
ma'am.
Emina.
Okay.
Anyway,
Nice.
thank you. God
Okay.
bless you.
Thank you. Thank you.
Thank you.